Welcome. This is Lynn Fraser with the Kilby Center for Recovery. I'm here today with Dr. Colin van Zoost. He works with a harm reduction program in Canada that I think everyone would be very interested in hearing more about it. So Colin, why don't you go ahead and introduce yourself and let us know a little bit about who you are and what you do.
Thanks, Lynn, and thanks for inviting me to chat about this. So as she mentioned, my name is Dr. Colin van Zoost. I'm an internal medicine specialist from Dartmouth, Nova Scotia in Canada. I predominantly work as an internal medicine physician and intensive care physician in Dartmouth, but I do some work with the university. I'm an assistant professor of medicine at Dalhousie, and I do a little bit of research within Dalhousie, some of it focusing on harm reduction models. And one of the main programs we've been looking at, especially here in Canada, is a harm reduction model around chronic alcohol use called managed alcohol programs.
So that is a program across Canada, or is it specifically at Dalhousie?
Well, it's predominantly actually a North American type program. There's a few places down in the States, I think, where it was initially implemented, but then it was adapted more to our political and our healthcare setting here in Canada. And so it's really a thing that predominantly happens here in Canada. A few places in the States, and then Australia has recently grabbed a hold of this. And part of the problem is there hasn't been any standardized approach that any center has taken from another center. Basically, we've had different managed alcohol programs across the country. So what we're first working on is actually doing a survey of all of the programs, looking at some of the pluses and minuses with them, inclusion, exclusion criteria, what patients they see, and trying to find a standardized approach, and then doing some research around it to evaluate the effectiveness of these programs.
So what are the main components of some of the programs that you're seeing?
So the main thing is, specifically with managed alcohol programs, there has to be a history of alcohol abuse that has typically failed other abstinent programs that have been available. The other issue with it too is typically the individuals who are in these programs have had complications from the alcohol abuse, other than the fact of physical complications, psychiatric complications, or they get to the point where they're experiencing poverty, are now homeless, and so are also facing other barriers from their social determinants.
So I know that homelessness is something that there are some programs now across Canada and the US, I'm sure, as well,
Yeah.
addressing homelessness and the cost benefit of actually providing housing for people. Is that part of the program that you guys are looking at?
Not specifically around that, but it does take on some of the same principles. What we're seeing is, from some of the work has done look at housing homeless individuals, we realize that housing is an extremely important and should be one of the initial interventions in trying to stabilize someone's health, but also their well-being. And so there's been a big focus on using a housing approach model here in Canada for homelessness. And that is one of the principles that tends to tie in with these managed alcohol programs. And the whole housing piece was really how they got started here in Canada. It initially started after there was a couple individuals in Toronto who froze to death due to exposure because they were not allowed in some of the shelter programs because of the continued alcohol use. And after that, then the city of Toronto came together and said, we need to make changes to how we house and provide housing for some of these people who have chronic addiction, specifically around alcohol abuse.
So what would that look like now for somebody?
Yeah, for everyone, it's slightly different, but as we talk about housing, that's part of the program. Is typically individuals would be housed in some type of shelter or facility. But the key around managed alcohol programs is it's not around reducing or focusing on abstinence of alcohol use. It's around about trying to break the chaotic cycle that comes along with addiction and alcohol abuse. and trying to provide more normality into their life so that you can focus on other issues and concerns that's going on with the individual's life. So typically what happens is starting in the morning when they wake up, they are provided a regular drink of alcohol, be it wine, beer, sherry, etc. And they basically get served regular alcohol, typically on the hour throughout the day. But as they are getting served their alcohol, this is when we start to implement some intensive case management. We work on hygiene. We work on getting some skills involved in these people. We get them connected with healthcare providers, with social workers. And so then we can start to look at some of the other aspects of their lives and not necessarily focus on the addiction to begin with, just breaking the vicious cycle that comes with addiction. And then once there is more stability in their life in general, then if it is appropriate and achievable, then there is a focus on minimizing alcohol use with the goal of abstinence. But if we do not get there, that's not a big concern.
So nobody would ever be kicked out of the program because they're not abstinent?
No, but there does have to be some buy-in from the individual as well, is that they do have to participate and follow the rules. And part of the rule is the alcohol that they're provided is the alcohol through the managed alcohol program. And if you're coming into the program drunk or inebriated, then you will not be allowed to participate, kind of thing. So there are some reasons why people may not be able to be involved with it, but typically most individuals, once they get in there and they realize that they can have more stability in their life, most feel comfortable with the program in itself.
Right. So how did you get involved with this?
It was mostly coming from my normal day job, working as an internal medicine specialist, because we see many of these people coming through the emergency departments, getting admitted to hospital, and a lot of times they're not provided the same care as another individual, mostly because of their addiction. Right. And a lot of times we don't see some of the reasons why they may have missed the appointment, why they may need to leave the hospital against medical advice. And a lot of times it's around dealing with withdrawal, with the addiction, with that kind of cycle of poverty. And I realized that a lot of these individuals weren't getting care. And a lot of them were out there suffering on the streets when they didn't need to be. And so it was definitely a need. And so I started to collaborate with some other members across the country who have been looking into research looking and doing some research in this, with the goal of actually starting a program up here in Halifax, in our major city here in Nova Scotia. Unfortunately, due to a few roadblocks, we haven't quite got to the point of setting it up, but I think now we have developed a research base and some of the evidence behind it saying these are effective programs. So hopefully in the future we can get one up and running here.
So I don't imagine that there's 100% public buy-in on providing alcohol to alcoholics. What's your experience with that?
So the experience that we've been seeing across the country is actually a very positive experience. Mm-hmm. We start to see, mostly for the individual, we see improved quality of life. They feel better. Most of the times they actually end up consuming less alcohol through these types of programs. But then even on the social side of things, we're seeing people reconnect with family that they may have not talked to in years. Mm-hmm. We're also seeing people use less of the judicial system, less in run-ins with law enforcement. And then also they end up using less acute care medical services. And we see the shift of the services more to planned medical care, which ultimately is a much easier way to provide care. Instead of just dealing with crisis care. So we're starting to see a big shift with individuals. That being said, it is not all necessarily just kind of puppies and rainbows with this type of a program. There are some downsides to it. And some of them is, what do you do if somebody is very young and has an addiction to alcohol with alcohol abuse? should we be allowing them to continue to drink dangerous levels of alcohol at a very young age? Because initially when these were developed, there is typically for your classic kind of middle-aged male who is an alcoholic. And typically they were dying of cirrhosis or other complications and couldn't get care in hospital. Most because they continued to drink. But now we're starting to see a much more broader application of this, and especially when we're dealing with younger populations, is what are the kind of ethics around that? Should you still be looking for abstinence in those individuals, or something like a managed alcohol program a good way of at least reducing the harm of their alcohol use? The other issues that we're running into is alcohol abuse just doesn't come alone. Typically, there's other substance abuse going on, be it with intravenous drug use, opiates, etc. And not all programs are designed to deal with those type of addictions. And so sometimes individuals can't continue to participate in the programs due to other substance abuse issues. So in general, we're seeing it is a positive, but there are still some catches with it. But I think that's the key to starting to get the public buy-in, especially when we look at government and policy and starting to fund a lot of these programs, which most of them do rely on some degree of public funding, is there needs to be some evidence behind it. And so hopefully some of the work we're doing provides that evidence. But I think in general, from a medical community, we are seeing that harm reduction strategies are starting to become standard of care in the community. We're seeing that with needle exchange programs, safe injection sites, methadone programs. They are now starting to become both socially and politically accepted, and there's good evidence from our medical literature to support that as well. And so I can see hopefully that managed alcohol programs would fit into that. The issue then we're now starting to realize and run into is, yes, that's great as an outpatient, but when they do need crisis interventions, acute care at a hospital, what does harm reduction look like in a hospital? That's kind of a much larger issue at times, because there's a lot more barriers with harm reduction in an institution compared to the community. But hopefully, at least if we can get the community on board, we'll start to see shifts happening in the hospital. And we're starting to see that already in places like Vancouver, when they're providing safe injection sites for the inpatient units who are using intravenous drugs. And also providing them with clean supplies kind of thing. So there is that shift even starting at a hospital-based level.
Okay. So I read a statistic a few years ago that the homeless program, housing homeless people in Denver, I think it was, costs about $25,000 a year to run the program per person, compared to upwards of $1 million often for people who are chronically homeless. So it makes sense financially. I think probably most people can get behind that.
Yes, and that's what we are seeing with some of the work we're doing just on homeless in general. The Housing First study that was done across the country looking at different communities where they've implemented a Housing First process. And basically for every dollar you put in, you usually save around $10. But for the highest system users and highest cost individuals, your return ends up being around usually $20.
Oh, wow, for every dollar.
Yeah, so this is a cost-effective approach, but it's also approach that respects the individual as well, kind of.
Right. So let's talk about that. So I think sometimes people can get behind it because, as the opioid epidemic has spread mostly into a lot more white people. And I did an interview last year with the North Carolina harm reduction program. And she said there was two things. One is the police were just like, this war on drugs is not working. We've been doing it for 30 years. It doesn't work. We need to do something else. But also that, judges, kids, a lot of people that were dying from opioids were kind of middle-class white people. And so it was reaching out there seems to be a fairly high tolerance to see addiction and death in poor communities or Native American communities or Black communities. And when it hit the white people, then there was kind of a wake-up call of like, well, maybe we actually need to do something about this. So what are you seeing in terms of kind of, you mentioned it earlier, when someone goes into the hospital into emerge, they might not get the same level of care. Are you seeing kind of the person with addiction as a person? Are you starting to see that kind of a shift as well?
To an extent, with a lot of exposure and education, that shift starts to happen. And this is something that I've been working on with a couple of med students, is really starting very early on in medical school, start to bring in these discussions around poverty, homelessness, addiction,
Right.
and start to bring that into both a culturally appropriate conversation with patients, but just in the fact of talking about simple things when you're talking to a patient, just like
Oh.
a simple question of, do you have enough to make ends meet at the end of the month? Because a lot of times we're under the assumption that people can automatically pay for the treatments we're offering or medication, or they can even read the material that we're giving them.
Right.
And it's shown that if you start very on in medical school, that people are more likely to be open and aware to homelessness, poverty, and addictions much later on in their training, and they're much more likely to want to either go into such type of field, or when they're in those situations, treat people more with respect and more open-mindedness. And so that's one of the big things that we've been trying, is really ingraining some of these mantras early on in the medical school training, and realizing that this is not an approach for everyone. This is an approach for people who have repeatedly failed at what we've tried before.
Right.
And if we can get to abstinence, fantastic. But if we can't, we can still offer some degree of care. The other thing that is happening mostly within the culture of our hospitals and community here in Halifax is having champions in the community and within the institutions who are really taking this on to bring out the awareness. So we're lucky that we have a group of healthcare providers called the Mobile Outreach Street Health, which are a group of healthcare providers that provide care on the street. And so a lot of times they're the liaison with the acute care setting when somebody has to come into the emergency department. And so that we have things organized, that there's certain people involved with the care, that we can make sure that they're not being judged or biased, or that we're at least culturally appropriate when we're addressing their needs. And so they have had a big influence in how we provide care, but also transition care from the hospital back to the community. And if we have somebody who's not willing to undergo our traditional treatment regime we would offer in hospital, they're still willing on continuing on some type of care when they leave the hospital. And then when you look at those really kind of iconic people within our medical community and hospitals, also having those champions as well. And there's been a couple physicians who have been mentors to me, but also who work in those hospitals to really push the boundaries and really show individuals that this is an effective and good way to provide care for some individuals, not all, but some. And so more recently, one of the medical students who's now a resident I've been working with, he's now starting to go through and doing a lot of just chart audits of individuals who are admitted to hospital for a bloodstream infection that infects the heart called endocarditis, and typically it's from intravenous drug use. And so what he's going through is looking at some of the interactions that happened with those individuals, who they saw in the hospital, where they started to run into issues, so that we can start to look at our system and process of and manage these individuals that are inpatient, so that we can provide the optimal care for them within their cultural needs.
I've interviewed Dr. Gabor Mate a couple of times now for this.
Yes.
And one of the things that he talks about in the realm of Hungry Ghosts, but also just generally as he's talking, is that he doesn't really know anybody who's using intravenous drugs, heroin, any kind of serious drugs like that doesn't have a lot of childhood trauma. So what are your thoughts on that, and how does that get folded into a program like this?
And I think that gets back to some of the principles we're learning about housing first. Is for us as the medical professionals, especially in things like internal medicine or the emergency department or the intensive care, that's what we're very good at and trained and good at identifying and fixing are those medical problems.
Mm-hmm.
But what we're not trained and what we're not necessarily good at is looking at more of those social determinants of health, looking at some of those adverse childhood experiences, looking at the psychiatric background and bringing all of that into the picture. And part of the problem is we get fixated and we think if we fix the medical problem, everything else is going to get better. But what we're learning now is if you don't start to address the homelessness, the poverty, these adverse childhood experiences, the concurrent mental health disorder and addiction, if you don't identify and address those early on in the care, no matter what you do from a medical perspective, you're going to fail.
Right.
And so I think where we're seeing the shift is, and this is starting to be driven by research, which is always important to get people's buy-in, is we're starting to see a shift. If we start to focus on the individual, we start to focus on the root cause of these addictions and other pathways to poverty, we're going to find the most success in actually treating that individual and not their medical problem. But that's where I struggle as a practitioner because I'm not trained in that. And when I'm seeing people in my private office or say at the community hospital I work with, I don't necessarily have those resources at my fingertips that are going to set this person up for success as they have in other situations. You know, I don't have somebody who can provide intensive case management. We don't have a program set up for, a sort of community training and trying to get these people integrated back into community and society. That's the difficult part because now we're bringing in much more different sectors, not just the healthcare sector, but also public health, housing, welfare, that kind of thing.
So that would have to be a real cross-disciplinary team and very well coordinated.
There is. And again, we are luckily getting there in the community right now with the mobile outreach street health because they work with a family medicine practice called the North End Community Health Center that is embedded in one of the lower socioeconomic communities here in Halifax. And they're starting to provide this multidisciplinary care assessment for these individuals. Along with the physical assessment and medical care that has to be provided by the physicians as well. But you start to realize that the social worker or, the therapist actually probably have the bigger impact on their health and providing optimal treatment for them.
Right. So you're not new to working with street-involved people. Do you want to talk about the foot care program?
Yeah, so that's partly how I got involved with some of the work I do. Very early on in my medical training, I started volunteering at it's kind of a soup kitchen, but it's a little bit more than that. It's called Sunday Suppers. So it's a meal provided for people who are in need once a week in Halifax, and it serves up to about 250 people at a time. It's slightly different than your traditional soup kitchen where you get in line, get a meal, sit down, eat, and leave. Where this is more built around community, where they try to sit individuals at tables, and then they serve each table all at once, so that you actually sit down and actually have your Sunday dinner with a group of friends. And so I started volunteering there, and they had a box of old shoes that they would give out to people who are in need. And so I kind of took an attraction to that and started giving out shoes and socks as a junior medical student. But then as my training progressed, I started to get into a little bit more of the foot care provided for these individuals. And then as I finished my medical school and got into residency, things just started to expand from there. I started to provide more foot care, brought in more medical students and residents. And then things really changed when 2 foot care nurses started to volunteer. Because after this point, I had no formal training in foot care. I was just pretending to be a foot care doctor. And then these nurses actually brought in, they were trained in foot care. And so then we really started to expand what we were doing, but the people we were impacting. We started to realize that yes, we may be looking after 10, 25 pairs of feet each weekend at this dinner, and giving out 50, 60 new pairs of shoes. But there were a lot of other people in the communities who weren't able to access this dinner. So then we started to move around Halifax over the next couple of years and go to other underserviced areas. One place was Mulgrave Park, which was public housing that had very high rates of diabetes and chronic illness. So we started to provide foot care there at times. Another place was actually more of the rural elderly poor in Cow Bay. So we started going through their Alliance Club because many of the elderly don't have the finances to provide foot care. So we started to reach out to many different populations who were at need within our community. Not only the homeless, but again, people who are with chronic illness or who are experiencing frailty, who are older. And so over time, we just started to provide more and more foot care. But on top of that, which I always talked about was the most important thing, was we provided new and basically clean socks and shoes for individuals, because if we could prevent the foot problems from happening in the foot place, they would need us to provide foot care. So that kind of stemmed another program called Fit It Forward, where we teamed up with some local footwear businesses, and they realized they had all this old stock in their basements that they couldn't get rid of. And so we started a program where we started now distribute brand new, well-fitted shoes to most of these individuals who were in need, to really start to prevent a lot of the foot care problems from happening in the first place. So, and that's a lot of how I started working with some of the underserviced populations here in Halifax, really just kind of getting to know them and really appreciate them as the individuals as you're sitting there intimately looking at their smelly, dirty feet. From the individual, it takes a lot of guts to allow someone to get that intimate and personal with you, and especially knowing that your feet aren't in good condition and they're probably embarrassed to actually show them.
Yeah.
But that really opened up the door to really get to know those individuals. But then we also took that as an opportunity to try to spread more positives around healthcare prevention, chronic disease management. So as the individual was starting or sitting there and we were caring for their feet, we would then start to talk to them about, well, have you checked your blood pressure? And we start to get medical students to check their blood pressure and start to screen them for other chronic illnesses like diabetes. We would talk to them a little bit about trying to minimize, smoking, alcohol intake, and then also start to line them up with some of the social services that were available in the city. So from what started out just giving out a few pairs of old used shoes, we eventually turned it into more of a whole chronic disease management program.
So has that been well received, or are you kind of a renegade that's kind of fighting to get this acknowledged?
No. At the very beginning, when I spoke with the university and the hospital about it, they didn't want anything to do about it because they were worried that, well, what if something happened and someone sued me because I cut their toenail wrong? So initially there wasn't a lot of interest from the university or hospital, mostly because they're worried about what they worry about, which is medical legal issues.
Right.
But I didn't worry about that at all because these individuals needed the care. I always thought that foot care is something that we are all trained to do in some form and capacity. So I guess by definition, I am trained in giving foot care because I've been doing it on myself for my whole life.
Yeah.
And I just didn't worry about all the other stuff behind it. And for good or bad, I think that's really what helped us to succeed. And then once people started to see what we were doing and the impact it was making on the individual, and how it was really bringing together the medical students with some of these community programs, but more importantly, the individuals in the community, then the university really started to see the positive of these types of programs. And then they started to actively get more involved, started to support our programs more. And more recently, they've actually brought together a multidisciplinary student-run health clinic for people who are marginalized or experiencing poverty. So now it was kind of a branch off from our program very early on. And so now there is actually a clinic, free clinic run by the university for these types of individuals.
Wow, that's cool.
Yeah.
Mm-hmm. So one thing that I've seen a lot of in the last 2 or 3 years is a lot more people now know what ACEs are. Do
Yes.
you want to talk a little bit about what the link is between the chronic, I mean, you mentioned diabetes, you're talking about foot problems. How would you kind of, and maybe you've got some people in mind that you could kind of use as an example too?
Yeah, it's huge. And it's probably, for me as a physician, more important in chronic disease management than it is necessarily in the work I do with poverty. So much of the day-to-day complaints I see in my office, and I hate to call them complaints because they're symptoms that individuals are experiencing, but even some of really what pushes on the acute care roles that I do, doing internal medicine consults or even stuff with intensive care, a lot of this is driven by adverse childhood experiences. Not only the chronic illnesses in themselves, starting very early on in life, increasing stress, we may see poor dietary habits, then we start to bring in substance abuse, which all may start to lead to more chronic illnesses like high blood pressure, diabetes, obesity, depression, stuff like that. But also how adverse childhood experiences start to drive a lot of the symptom complex that individuals can develop later on in life. A lot of the concerns I see for palpitations or the heart racing or fatigue or, chest pain. If you really weed out the people who have medical issues for those complaints, which really in general is probably less than 50%, the other group of individuals, if you start to peel back those layers of the onion, you'll realize that most of what they're experiencing is not because their heart is racing too fast,
Right.
or because they have a problem with their thyroid gland. It's because they had developed these adverse childhood experiences early on in life. They never quite dealt with them or realized how they could cope with them. And now as they're older, they're manifesting as physical symptoms and complaints. This is, again, an area where I struggle at because I am trained to treat medical issues.
Right. Mm-hmm.
I am not trained to deal with adverse childhood experiences. And really the system I work in does not support me in going down that avenue, because to get to those deeper areas in an individual's life, it takes time.
Right.
And it really takes work on both the practitioner and the individual to get to that point. And I work in a fee-for-service model where you're not remunerated and you're not supported to really spend that time that's needed with the individual. And in general, I don't have the training to really get there. I might be able to get there, but when I get there, I don't know what to do with it.
Right. Mm-hmm.
But we have started to identify that these somatic complaints or these medically unexplained symptoms that typically do start early on as these adverse childhood experiences, again, just like poverty and homelessness and a lot of addiction, you really need that multidisciplinary approach. You really need to tackle it from the root level. And so now, at least our province have started to identify that these are high system users that have a lot of symptoms that are suffering, and starting to put in the pieces of the puzzle that can help support them and get them to identifying how some of these adverse experiences are really driving the way they're feeling as an adult. But unfortunately, as the general medical community, we have a lot of biases towards these individuals. The people with fibromyalgia, chronic fatigue, and right away, if they do actually have other complaints, other issues, they commonly do get overlooked, under-investigated, and attributed to these somatic complaints.
Right.
And so it does continue to kind of cause us to struggle sometimes in optimally managing these individuals, but it's even harder to get to how do we best manage them and treat them and fix the underlying problem. That's, I think, the tough part with that.
Well, and it's, I know from my own experience and from working with other people that healing childhood trauma, developmental trauma is a long-term process. It takes safety, it takes the right kind of care. And I can see it must be frustrating for a medical doctor who has 10 or 15 minutes. And once you're awake to it, once you can see it, you can see that that's probably what's underlying this, especially with addiction.
Yep.
And then that must be kind of like one of the things about trauma is that people tend to feel very hopeless and very helpless. And it almost seems like that would trigger something similar in a doctor who's trying to help.
It is very difficult because a lot of times there's only so much we can do.
Yeah.
For me, the one positive I see is when I do have that individual in front of me, and in that very short period of time I have with them, 15 minutes, half an hour, that I actually get to the point where they have insight in that a lot of these adverse experiences are driving their current symptoms, the way they feel and what's happening. I tell them that I'm not going to be the person who's going to fix that, but the key is you at least identify it. But now that's when the hard work begins, because the hard work is now going back and really reliving those experiences and figuring out how they have pushed that individual to where they're at right now. That, I think, is the hard work. But yes, it can be very frustrating, and with that sensation of helplessness, a lot of times dealing with these individuals.
Right. The thing too about that is there's so much shame. I mean, there's shame about addiction. There's shame about all the ways that, people feel they're a loser because life isn't working for them. And then to have somebody with credibility say, you know what, this is how it works. You have these kinds of experiences, these adverse experiences, and this is the kind of stress your body's under. There's so much more addiction. There's so much more of these things. That's just how it works. It's not something wrong with you. It's just your system is responding to the kind of experiences you've had. And that can be healing just on its own.
Yes.
I'm going to hear that.
Yeah. And the thing I always try to do is help normalize the situation for them and make them realize that there are many other people who are going through the exact same struggles that they're going through, all for different reasons, and all of them have their own battles that are different, but in general, they're not alone in this fight.
Right.
But also that it is going to be a struggle, and it will continue to be a struggle, because this is not a quick, easy solution. And it's, for the most part, not going to go away. It's always going to be there with them. So it's how to best manage that.
Right.
And that's where I've started to change a lot of my approach when I'm dealing with people with addiction, but even people with chronic illness is, okay, yes, you can identify the addiction or the chronic illness is there. Yes, in general, I can tell you what the best evidence is, how to treat that medical illness or addiction. But for that individual, you then need to know who the individual is next to know how you are actually going to implement that plan. And that's really where now I try to spend a lot of what I do with these people from a one-on-one perspective is trying to understand the individual. And then trying to get to the point as efficiently as I can, but as thoroughly as I can, and knowing what role I have in the process and what role somebody else has.
Right.
And making sure that I don't spend too much time on roles that I'm not best equipped with, but trying to get them to the right person they need. And sometimes that's a lot of time early on with me, especially if they do have uncontrolled medical illnesses or complications from their addiction.
Right.
But once that is dealt with, then it is about knowing that individual and working and getting the trust of the individual, so that when I am ready to hand them off to somebody else, they're going to go there with trusting relationships already.
Right.
So hopefully they can be built upon it. Knowing that a lot of times it's 2 steps forward, 1 step back, but again, hopefully kind of building back that trust in the medical community, but also the system and processes in place at actually helping them deal with their addiction or chronic illness.
Well, and this is a population that have typically not been treated well or with respect. So it's kind of an uphill battle there. But what a wonderful thing for someone to experience that.
And I think one of the things we're trying to do is eliminate some of the easy barriers that we can. And I think one of the major barriers that we provide is the way we provide healthcare in general.
Mm-hmm.
Most healthcare is all dictated by a family physician that then books appointments, that then has to go to these hospitals for these appointments. And for 99% of our population, that system works very well. But for the small group of the population, regular booked appointments don't necessarily work well, or having that scheduled doctor's appointment at, 8 o'clock in the morning that you have to operate a kiosk beforehand, and then sitting in a waiting room for an hour, start to go through withdrawal, have to leave. Those aren't ideal circumstances for these individuals. And so what we really try to do is, when we can, institutionalize, demedicalize a lot of our healthcare interactions. Mm-hmm. And so now what we start to do, we'll go meet these people in their community, on the street, at the coffee shop. And again, start the discussions not about their health, but about who the individual they are. And that's where a lot of what our mobile outreach street health team does, is they push the envelope of how they provide care to these individuals. Mm-hmm. And as part of the program we've done with them, we've done a lot of work around vaccination and improving vaccination rates. And we do a mass immunization blitz where we go to all the kind of shelters, soup kitchens, street corners, and we provide immunizations for them. And I always love it when the nurses at this time send me the most obscure locations they were giving out vaccines at, Okay. So it'll be the bathroom in the back of a bar, or, another one would be down this back alleyway, where they're actually be immunizing individuals. But by going out and into the communities, into where these people live and spend their time, we have shown that you can still provide good health care. And even just when we look at vaccinations, within 2 years, we doubled our immunization rates to certain vaccines just by going out to the communities and vaccinating people in the community. Instead of waiting for them to come to us, we start to just go to them. Yeah, and that has made a big difference in providing care. And again, that's where we start to see some of these harm reduction models in the community, is really they're starting to be embedded in the community, and they're starting to provide some of this care in a situation and environment these people are comfortable with being in. They're not necessarily comfortable being in that sterile, medicalized kind of office, where they feel much more comfortable if they're still able to remain in their own area and community.
Right, right. So what advice would you have for someone who's struggling with addiction? Maybe someone who's just really starting to tune in about their own trauma background and how difficult it is to stop. What are some of the things you might suggest?
So that it's going to be difficult. But there are supports out there for them. And I think we're learning more and more each day how we can best provide those supports. Mm-hmm. And that we're starting to get better understanding of the concept of addiction, but also how addiction is tightly intertwined with both mental health as well. And so we're starting to see these shifts of where you used to have mental health as one referral form, addiction was the other referral form. They didn't even talk to each other. Right. Now we've got to the point where we're identifying that really mental health and addiction run hand in hand, and we start to come up with these concepts of concurrent disorders, where we actually treat them both at once. So I think from our healthcare perspective, we are slowly getting better at providing the optimal care for individuals with addiction. However, a lot of that still relies on resources that are available in communities, but we're moving in that direction to provide the best care possible. And then knowing that a lot of people struggle with making it to abstinence, that we're starting to see more and more acceptance around, especially around harm reduction, and still being able to provide care, still being able to treat them as the individual,
Right.
if they're not able to get to that place of abstinence yet. And so I think it provides more options for them. And I think it provides it in a patient-centered way or an individual-centered way. We're working at the individual to choose their goals of where they want to get and not forcing our goals upon them. So I think both with those two changes in how we're delivering care, I think it does provide more of an opportunity for people with addiction going forward, and especially as this gets more and more accepted in both society, but also our medical community.
Mm-hmm. Well, something else that strikes me too is that when you're in the community, then you're able to pull in community resources, elders, different people who can have a big impact on just that inclusion, because people with addiction often feel so isolated, especially with mental health issues.
Yes, and I think that's key to all what we try to do is if you don't get community buy-in, no matter what you're trying to do within a community,
Right.
you're not going to succeed. You need to be and provide care that's intertwined with that community, with their values, where they come from. And that's where we see in Halifax, as a great example, is our primary care backbone for a marginalized community is embedded right in that community. They know the individuals well. They know the shop merchants who also are in that community, so they can start to look at not only providing the medical care, but try to provide fresh, whole fruits and vegetables for individuals in that community.
Right.
And then they know the police officers who are commonly there, so they say, well, instead of taking them to the drunk tank, bring them to us. We will help them to get recovered and go from there. So that is the key to it too, is being immersed with the community, but not trying to adapt every model to every community, but working with that community and working with what models work with them and not trying to reinvent the wheel.
Right. Well, there's a lot of hope in this approach.
Yeah. No, and that's even though, especially when we look at our opioid epidemic that we're experiencing right now, and that it is a major public health problem, and there are lots of people who are suffering from it, we are pushing the envelope of how to provide the best care we can for these individuals, and it is getting better.
Right. So what is the status in Halifax and Nova Scotia around using is it naloxone?
Yeah, naloxone. We're starting to now give it these naloxone kits out through the emergency department.
Oh, okay.
And then we're starting to slowly make more of an effort to start to also send people home from the inpatient units with the naloxone kits. Mm-hmm. It hasn't been as quick of an uptake as we've seen in Western Canada, just because we don't have the same numbers and problem as they do, say, in Vancouver and stuff like that.
Right.
But we are starting to see that. And we're also, seeing a lot more opioid replacement therapy, especially trying to get people while they're in hospital switched over to things like methadone.
Oh, okay.
That's slowly starting to happen more and more as time goes on. So there is getting more and more uptake from both the hospital setting and the community setting of some of these harm reduction models. And that's why I think we're finally seeing that harm reduction is again starting to become standard of care in the community, which is very exciting.
Mm-hmm. Mm-hmm.
These programs across the country are growing and we are getting the evidence. So hopefully with time, with getting more people involved, we might be able to get one up and running in the next at least 5-10 years, I would hope.
Right. Good. Yeah, those things, it takes a while to shift something as massive as our public healthcare system.
Yes, yeah, and again, is trying to find the funding, because a lot of these programs, when they start, the funding comes privately, and then once they see that it works, and then the public funding comes, right? So it takes a lot of effort to try to coordinate things initially, but typically once they get up and running, they start to be self-sufficient if they're run appropriately.
Well, and that the experience of people across Canada will help with that too then.
Yes, exactly.
Yeah. At some point, that'll be standard treatment. Yeah.
Yeah, and we're already starting to see it shift to other countries as well, where places like Australia and stuff are starting to adopt this type of model as well.
I did a really fascinating interview with Dr. David Best in Europe. He's in the UK, and they have recovery cities. There's one in Australia and a couple in Europe. And the whole city, they have these interdisciplinary teams. They work with people in prison. They work with people with addiction. And the whole city kind of gears up around how can they support healing and sobriety. It's really interesting.
Well, and that just goes back to that same fact that you really need to tackle this from both the social determinants of health lens, but also from the addiction and medical side as well. It does take that entire holistic approach to get where you need to go.
Yeah, it does. Yeah. Well, thank you very much.
You're very welcome. It's my pleasure.
Go to KillibyCenter.com, Radical Recovery Summit. For access to the interviews, you can watch them free online, or you could purchase an all-access pass. KillibyCenter.com.